Hello, everyone. My name is Annie Garniva, and I'm the Vice President of Policy and Special Initiatives of the New York City Employment and Training Coalition. Apologies for the couple-minute late start on our end. I am proud to moderate the discussion today with our fantastic set of panelists, and thank you to all of the members that have joined us this afternoon. Thank you again to Amazon, Google, LinkedIn, Meta, and Verizon for sponsoring this series. NYC ETC, as many of you know, supports the workforce development community to ensure that every New Yorker has access to the skills, training, and education needed to thrive in the local economy. And that, sorry, I'm just gonna mute everyone. Sorry, having a little technical difficulties. NYCTC supports the workforce development community to ensure that every New Yorker has access to the skills, training, and education needed to thrive in the local economy, and that every business is able to maintain a highly skilled workforce. Our membership is composed of over 200 workforce providers, educational institutions, and labor management organizations that provide training and employment services to nearly 600,000 New Yorkers. Today, in this third installment in our Industry Needs series, we'll discuss the state of the healthcare sector here in the city. Before we begin, I'd like to share a couple of thoughts, and in planning for this program, we were so impressed with the long-standing, strongly formed bonds between service providers, employers, and in this sector. As James Parrott from the New School will share in his labor update momentarily, healthcare employs 14% of the workforce in New York City. That's huge and makes it the largest sector by far of employment. Not surprisingly, healthcare is also one of the most common training and placement services offered by coalition members. We'll look forward to a lively discussion today that will build on the strong bonds you've formed with the sector already and envision new paths as we move forward in post-pandemic recovery and a much-needed intentional recovery for all. All participants should know that you'll be muted for the duration of the webinar. I'll moderate a discussion with our speakers and discuss the state of their communities and what else can be done to keep healthcare businesses open and get workers employed. Before we jump into the panel discussion, we'll hear today from James Parrott, Director of Economic and Fiscal Policies at the Center for New York City Affairs at the New School, who will provide a labor update on the healthcare sector. Welcome, James, and nice to see you. I'll let you take it from here.
Thank you, Annie. Good afternoon, everyone. It's an honor to be here again to join my colleagues at the Employment and Training Coalition and a great panel of experts from the healthcare industry. Thank you all. If I could have the first slide, please. Thank you. So what I'd like to do today in about 10 or 15 minutes, try and limit it to that, give you a sense of the healthcare industry and how it's been affected by COVID. So the impact in the healthcare industry, of course, is a lot different from what it is in many parts of the city's economy that have been hit very hard by COVID in terms of job losses and so on. In the healthcare industry, that's not the case, but it has been the subject of enormous pressure and stress because it is the healthcare industry after all, and it's been at the focal point of the medical response to this horrendous pandemic. So that's put a lot of pressure on this really essential doesn't do justice to the centrality of the healthcare industry in a pandemic. This has been, a really horrifying time in many ways. We've seen the death of over 34,000 New York City residents in the past 2 years as a result of COVID. And of course, like many aspects of the impact of COVID, very unevenly felt. So we'll look at the healthcare industry overall, look at the major sub-industries, how they've been affected and how they're being reshaped by COVID. We'll look at the demographics of the workforce, occupations and pay, and zero in a little bit toward the end on the impact on healthcare workers and the implications for workforce developers in the context of an evolving sector overall. Next slide, please. So before we get into the healthcare sector, let me give you just brief background on the broader economic picture in New York City in terms of the COVID economic impact. So, as of December 2021, which is the latest month that we have the employment data at this point, New York City's recovered only 55% of the jobs lost in those initial 2 months between February and April of 2020. That means that New York City is still short over 420,000 jobs compared to what we had in February of 2020. Those losses have been heavily concentrated in the face-to-face service-oriented industries, predominated by low-income workers of color and young adults. The unevenness in terms of its impact on workers in New York is dramatically evident in the disparity in the unemployment rates. For the fourth quarter of 2020, the overall unemployment rate in New York City was 9.1%. However, for whites, it was only 6.3%. For blacks, on the other hand, it was 15.2%. That's currently what it is. For blacks in New York City, 15% unemployment. For Latinx workers, 10.2%. And for Asian workers, 6.4%. This is a very turbulent labor market. We're all trying to figure out sort of where things are headed and what things are likely to look like a year or two from now. We're not going to get back all of the jobs that are lost. And there's going to be there is a massive workforce redeployment need to identify workers losing their jobs, identify where there's employment demand, and provide people with the skills and the training and education they need to access those jobs, and do a better job than what we've done in the past in New York City in making sure that New York City residents are able to access good paying jobs that will result from this in time. Next slide, please. So turning to the healthcare sector, as Annie noted, this is the largest single sector in the New York City economy. Over 650,000 people employed in this sector. When you put together the public and the private component of this, most of it's in the private sector. This pie chart shows the major component parts of healthcare. Home healthcare is the largest. It's a third of the total right now. 219,000 jobs before the pandemic. We'll see in a minute how that number has grown further since then. Then there's the rest of the ambulatory sector. That's doctors' offices and medical labs and so on. We have another slide where we'll detail some of those component sub-industries and look at how employment has fared in those sectors. Then there's the private nursing and residential care facilities, which has been hit hard by the pandemic and by job losses there. Private hospitals employ about 170,000 people. And between the public hospital system and the Health and Hospitals Corporation hospitals and the city's Department of Health and Mental Health, another 60,000 or so workers. So altogether, over 650,000 workers. Next slide. So this represents 1 in 7 of all payroll workers in New York City. It's a sector that saw a lot of growth in the decade before the pandemic, with, of course, much of that being concentrated in the home health sector. There was tremendous improvement under the Affordable Care Act in the several years before the pandemic in bringing down the percent of New Yorkers who were without health insurance. So that number declined from almost 15% in 2010 to less than 7% in 2019. That meant that about 570,000 New York City residents at that point did not have health insurance coverage, and that includes coverage by Medicare and Medicaid. A recent Robin Hood sponsored report found that a third, this is before the pandemic, a third of New York City adults have high health care needs. And they define that as either multiple chronic conditions or work limiting conditions or severe psychological stress. So this was before the pandemic, significant part of the population with high healthcare needs. Now, a lot of people have lost health insurance during the pandemic. We don't know exactly how many, it's in the low hundreds of thousands, but we do know that there's been a dramatic increase in the number of people qualifying for Medicaid in the past 2 years. There were a lot of people on Medicaid before the pandemic. Since the pandemic has started, 750,000 additional people have qualified for Medicaid in New York City. That's an astounding number. At this point, over 4 million New Yorkers, New York City residents, receive care under Medicaid. That's had tremendous repercussions that we're still trying to understand. Next slide, please. So I said we'll look more at some of the detail of the recent employment changes in the healthcare sector. So overall, employment is more or less where it was before the pandemic, but there have been shifts within some of the components. The home healthcare industry did lose jobs initially as home care workers were not able to continue providing services. That number did recover toward the end of 2020 and has been growing, moderately since then. And now there's been a net increase of 18,000 home health care workers in New York City compared to before the pandemic. The other parts of the ambulatory care sector include physicians' offices, outpatient care centers, dentist offices, offices of other health practitioners, including mental health practitioners. While those numbers are not big, you can imagine that demand for mental health services has increased tremendously under the pandemic. And you can see some of that reflected in the employment numbers here. In some of these industries, we don't have data as current as December of 2021, but we have it through the first half of 2021. So that's why the numbers for some of these industries stop in June of 2021. Medical diagnostic labs have grown also. And then the final sub-industry here in ambulatory is ambulance services themselves. So outside of home health care, the rest of the ambulatory care sector is actually down a little bit. And you can imagine, why that's the case. Doctors' offices are not back to normal, whatever that is, whatever that's going to be in the future. They're certainly not back to where they were before the pandemic, with a lot of people still being reluctant to visit doctors' offices and so on, even though medical care needs have risen substantially. Employment in hospitals is pretty much, remained constant in terms of its aggregate level. There's been a lot of turnover. People have left, and hospitals have been aggressively recruiting other workers and so on. Nursing care facilities, as I indicated before, has seen some drop off in the employment numbers. So these, there's a question in the chat. These numbers are in thousands. I'm sorry about that. That should have been indicated. So the total healthcare employment in the private sector, anyway, was 603,700 in December. Next slide, please. So in looking at who the healthcare sector workers are, very heavily female. 3 out of every 4 healthcare workers are female, compared to about a little under half in the broader economy overall. They're much more likely to be workers of color, especially those who work in the public sector, whether in the health department or in health and hospitals. They're much more likely to be Black. So 34% of private healthcare workers are Black, 44% of public healthcare workers Black, versus 20% Black representation in the city's workforce, in the private workforce overall. A heavier representation of immigrants in healthcare, and healthcare offers a wide range of employment opportunities. There's an overrepresentation of well-educated workers with postgraduate degrees, and fewer workers with a high school education or less. And when you put it all together, look at it in relation to the rest of the private sector in the city's economy, many more workers in middle pay ranges and fewer at either extreme, the low extreme or the high extreme. Next slide. So I have 2 slides here that have detailed occupations. So 2 things important to keep in mind here. So the first slide is on healthcare practitioners or healthcare professionals. So these tend to be the higher paying positions. Then we'll look at healthcare support occupations. And the other thing to keep in mind is that the employment levels here are for the New York metropolitan area. So it's broader than just New York City. But what is applicable in New York City is the percent distribution. So registered nurses are 32.4% of all healthcare employment among in this first slide among practitioners and technical occupations. So that's true in the metropolitan region. It's probably pretty close to what the numbers are actually in New York City. So you can see, we're not going to talk in this forum about doctors and surgeons and dentists and other people with an MD degree. We're going to focus on other occupations. So here, what's of interest is registered nurses, a big share here, LPNs, big share, pharmacists, pharmacy techs, and then a lot of technical healthcare occupations, clinical lab technologists, physical therapists, EMTs, paramedics, nurse practitioners, and so on. And in the final column here, you can get an idea of the average salary in the region for these occupations. Next slide. So this slide focuses in these 2 broad categories, professionals and support. They're roughly of comparable size. They're each, again, within the region, employ about 600,000 people. This sector is overwhelmingly, dominated by home health care. 2/3 of this sector overall, with, of course, very low pay, and we'll talk a little bit more about that at the end. But here you can see, a number of healthcare support occupations, and many of these are experiencing high demand and need right now. Nursing assistants, medical assistants, phlebotomists, physical therapist aides, psychiatric aides, medical transcriptionists, pharmacy aides, and so on. So a lot of these jobs pay, in the $30,000 to $50,000 range. Next slide, please. So in looking at frontline healthcare workers, in New York City before the pandemic, it was very uneven. I mean, this is still true to some extent, very uneven community access to primary care. recent analyses have shown that that deficiency was addressed to some extent because emergency medical responses services were provided where they were needed, and people were served in their communities. But the system was not set up before the pandemic to provide equitable access across the entire city. So that's had repercussions for how the sector was able to respond. Going into this, the hospital industry was not well prepared in terms of PPE equipment and equipment needed. And there was also no overall structure for coordination because, frankly, we haven't had a lot of pandemics in recent years, and there was no mechanism in place on how to coordinate that. So there's been a lot of experience gained in the past 2 years as a result of this. So the medical system in New York City, I think, has served all of us really, really well, and we're all deeply indebted to the sacrifice and the commitment of healthcare workers. They've experienced incredible demands, long hours, stress on the workers, many of whom were from the communities hardest hit, having to deal with their own families' health challenges as well. So it's really been, an industry that's been at the center of a lot of turmoil in recent years. And of course, these healthcare workers have to deal with their own, personal health risks, which have been exacerbated given, where they work. And as noted before, dealing with healthcare issues among family members as well. So this is a workforce that's undergone a lot of physical and mental health pressures. And that's a factor in thinking about how to approach the workforce development needs, dealing with burnout, the mental health care needs, the stresses that healthcare workers have been through. Next slide. So the challenges for the workforce community overall, healthcare workers, like many workers, are experiencing reluctance to return to work. At the same time, there are many workers who have become unemployed and are anxious to access training. They understand that there are employment needs, occupational needs in healthcare. So it is a time for the workforce development community to rise to the challenge and address these needs. There are several high demand occupations that we just list a few examples here: respiratory therapists, surgical technologists, pharmacy technicians, EMT paramedics. The healthcare system overall recognizes a need for more of a community healthcare orientation, and that's the importance of that has really been highlighted by the need for healthcare providers to be in a very trusting relationship with community members and patients. Very high demand for home care workers. The gap between the need and the supply is probably greater than it's ever been before. This, of course, is compounded by the fact that this is a sector where the pay is still, around $30,000, maybe a little bit more than that, but not a lot more than that. It's still very, very low, given the importance and the overall budget sense of how important it is to keep people in their own homes. It's much less expensive to provide medical and maintain people that way, rather than if they're in nursing home or hospital settings. Digital divide challenges have been a big issue for providing healthcare services, providing training, access to telehealth, and so on. Many parts of the healthcare sector have turn to telehealth, but not having, adequate digital access is really an impediment there. Next slide. This will be my final slide, just to close with some, broader policy issues. So there's a clear challenge to create a more resilient healthcare system to better address the needs of underserved New York City neighborhoods, to better prepare us for future outbreaks, and to address inequities in community needs. A clear need to raise the pay for home care workers, and in some cases, the hours they're able to work. Medicaid is not covering as many home care hours as before, and that's complicated. It presented challenges for many home care workers in getting sufficient hours. So again, this is an area where there's going to be strong demand in the future. There are opportunities here, but it's starting to be a broader public policy recognition that the pay really needs to be adjusted. And sort of speaking to that in part, the Governor Hochul in her executive budget proposed, she focused on the fact that the healthcare going through all of these changes we've been talking about, and that more resources are needed from the state to rebuild the healthcare workforce, to help to better retain and recruit workers, to create new pathways for healthcare careers, and more accessible credentialing programs, and so on. The state budget is, as we all know, is currently being debated in Albany. By the end of this month, we should have, hopefully we'll have some clarity about where all this is going to end up. But it looks like there clearly will be, a ratcheted up public commitment to invest in the healthcare workforce and begin to address some of these broader needs that have clearly been highlighted by the experience of the pandemic. So let me stop at that point. Thank you very much. I'll turn it back to you, Annie.
Thanks, James. Very thorough and detailed as always. Now I will introduce our incredible panel. Joining us today are Tanya Isaacs, who is Senior Vice President and Chief Human Resources Officer at the New Jewish Home. We also have Ivelesse Mendez-Justiniano, who is the Chief Learning Officer at New York City Health and Hospitals. We have Gail Monroe-Perry, Vice President of Talent Development and Acquisition at the Institute for Family Health. Dan Pitchinson, Executive Director at Ryan Chelsea Clinton Community Health Center. And Jenny Tsang-Quinn, Senior Vice President of Clinical Effectiveness at Maimonides Medical Center. Hi, everyone. Nice to see you. Thank you so much for joining us. And before I go on, I know that we get asked this question every time. Everybody that's in attendance today will get the presentation that James just went through, as well as this is being recorded. So you also get a link to this to our YouTube channel afterwards. All right, let's get started. So if before we kind of start having a broader discussion about the healthcare sector, I was wondering if each of you could just quickly introduce yourself, your company, and your organization's role in the healthcare sector, as well as your personal background with the industry, because I know we have a very wide variety of perspectives today. So Tanya, why don't we start with you?
Sure. Hi, my name is Tanya Isaacs. I work for the New Jewish Home as the Senior Vice President and Chief Human Resources Officer. The New Jewish Home has 2 nursing homes. We provide home care, adult daycare, and a few other services, all geared towards the elderly in New York City. And I agree with a lot of what I'm seeing going on in the chat because of this workforce shortage. Patients are foregoing home care because there just are no staff, and I look forward to seeing how we explore this here.
Thanks, Tanya. Ivelesse?
Hi, good afternoon, Everyone. My name is Ivelesse Mendez. I am the Chief Learning Officer for New York City Health and Hospitals. And New York City Health and Hospitals is the largest public healthcare system in the United States. We employ about 49,000 employees across the 5 boroughs. And we have hospitals, clinics, correctional health, and basically our locations are where you live and where our patients live. We're very proud of our diversity. We serve over 1.4 million New Yorkers, and of that population, we have about 25% that are limited English proficiency. So we have a lot of needs, and we're also hiring. So I look forward to the conversation.
Oh, Gail?
Good afternoon, everyone. My name is Gail Monroe-Perry. I'm the Vice President of Talent Development and Acquisition for the Institute for Family Health. We are a federally qualified health center, and we have 32 locations throughout the state of New York, the majority of them being in Manhattan, Brooklyn, and the Bronx. And we're also in the Mid-Hudson Valley area, which are areas New Paltz, Kingston, Ellenville. I think that what makes us pretty special is the fact that our mission is to provide quality health care to anyone who walks through our door. So whether you have insurance or not, you will be able to get service from us. And I think that's a beautiful thing. But we're also believe in life learners, and we have 1,300 employees, and we too are also looking for the talent that's out there that's willing to be an advocate for our mission.
Thank you. Dan?
Good afternoon. My name is Dan Pitchinson. I'm Executive Director at Ryan Chelsea Clinton Community Health Center. We are a community health center and Hell's Kitchen and a part of a larger network known as Ryan Health. And similarly to the Institute for Family Health, we provide healthcare as a federally qualified health center, primarily in Manhattan, serving underserved individuals, most living 100 to 200% below the poverty level. Most of our patients are BIPOC individuals. We provide primary care, dentistry, optical, and behavioral health services. And the way we're able to do this, for people who might not be familiar with the federally qualified health center system, is we receive federal funding and enhanced Medicaid rates to treat anyone regardless of their ability to pay. I'm also the incoming chair of the workforce committee of our statewide association, the Community Health Center Association of New York State, also known as CHCANYS. And we are looking for talent all across our state to boost the healthcare workforce.
Thanks, Dan. And Jenny?
Hi, everyone. My name is Jenny Tsang-Quinn. I'm a Senior Vice President of the Department of Population Health at Maimonides Medical Center. And part of my day-to-day is to help our clinical teams, particularly in primary care, to deliver high-quality care to our patients that is both efficient and effective. An important part of my work every day is to make sure that we have the right workforce in place to deliver on that goal. So I don't work in HR. I'm actually working in a different capacity. But one of the interesting things that I'm currently doing is providing some workforce development help to an initiative that was launched in partnership with Maimonides called the Brooklyn Communities Collaborative, which is a not-for-profit 501c3 umbrella organization of health, education, labor organizations, CBOs, city, state government, foundations. And our goal is to use an anchor mission approach to encourage Brooklyn-based high-performing organizations to work together and to harness economic power through hiring, purchasing, and investing in Brooklyn. CUNY, One Brooklyn Health, Maimonides are all among the anchor organizations in this initiative. And there are a couple things that are underway, but the one that I'm really passionate about, it's called Citizen Share Brooklyn, and that's where we're designing a borough-wide regional healthcare-focused workforce development ecosystem. So how do we build a system where community members can access on and off ramps to education and training, and then get connected to jobs at anchor institutions? So I'm looking forward to our discussion today. Thank you.
Thanks, Jenny. So before we start talking about your particular organizations, would love to hear from some of you about what you thought about the labor update from James. And if you could provide some more details on the effects of the pandemic has had on the economic and talent landscape from your vantage point, as well as how this has impacted kind of your hiring and talent development practices, what trends in hiring you've noticed over the last few years that our audience should know about. So why don't we start with Gail?
Okay. Well, I think the first thing that I would say is that I was very intrigued by the numbers, but the stats were from 2019. And I think that the information might be a little different today post-pandemic. I know that we had to take a concerted effort to look across the board at salaries because it's a candidate's market at this point. It doesn't matter what level that you're at, but it's definitely a candidate's market. And the things that they're concerned about is very different pre-COVID than they are now. I mean, you really have to deal with flexibility, being able to work remotely. Of course, the salary is up there. What kinds of incentives do you have? And I've never had so many questions in terms of with the benefits because it's important. But what might be important to me at my stage of my career is very different than maybe the individuals that are coming into the workforce now. I think that they're very much more concerned with quality of life. What kind of contributions are you giving to the community? And they're very serious about that, as opposed to the salary being as important. I will tell you that we are in a crunch. We have been for a while in terms of trying to fill our positions because there is so much change. We find that people do not hesitate to not show up for interviews or to start a position and the next day maybe even leave because they've been given a better offer. I don't know, probably some of you have heard the stories of when you're talking about RNs and LPNs and medical office assistants, we're really hit hard, but you have RNs that are making maybe $250,000 for a 6-month period. And as a federally qualified health center, that's something that we would never be able to really compete with. But it has caused us to really make sure that our retention and recruiting boards, our dashboards are fluid and constantly being adjusted to the needs of what's happening out there in the market. It is constantly changing. So we're trying to find ways to not only recruit, but retain the individuals that we have in our organization at this point. And I think that that's really critical, being able to change. I mean, the only thing constant in life these days seems to be change, and you have to be able to adjust and flex along with it. The Great Resignation is serious. I'm sure everyone in this room has heard about, by the end of the year, probably 40 to 50% of the population, the working population, will have changed jobs for various reasons, but there definitely will be change. So I think technology is really important. We've got to learn to work smarter and really be involved and networking with, like, my fellow panelists here in terms of what are the best practices and what are you finding, and talking more and communicating more. And that's why I was delighted to be a part of this panel.
Thanks, Gail. And I'm already seeing in the chat a couple of people kind of asking to be connected. And so just so everybody knows, we'll follow up with panelists after the fact to kind of confirm that we can share contact information, and then we'll send that out to attendees. So that is definitely one of the goals of this event. Ivelesse, what about you?
So Gail very eloquently shared some of our pain points as well. So the pandemic has really affected us in terms of not only our clinical staff, but also our non-clinical staff. And what we're seeing is a little bit of a dichotomy in terms of the wants and the needs. One thing that's taken the forefront is the option to have remote work. So we're finding that some of our clinicians, they're looking for those positions that allow them to work from home. So when you're thinking about community-based work, you're thinking about your telehealth, those are areas that are largely growing. But in healthcare, I think one of the unique challenges that we face is that we don't often have the option to telecommute. So the remote workforce, that's non-clinicians, not so often. But when we have clinicians, we need them on site. And so to Gail's earlier point, individuals are looking for work-life balance. They're looking for flexibility in work. They're also looking at comparative pay. they have options. So what are we doing that's going to put our organization above others? One of the things that as individuals come to me, one of the things they ask is benefits, not so much in terms of medical, because that's something standard that we provide. But in addition to that, they're really interested in their development, whether that be supporting them in degree-bearing fields, supporting them as part of the workforce, and really providing them with exposure opportunities. And one of the things that we've also learned is that the individual of today will come to the workforce and they may stay with you for 1, maybe 2 years, maybe 2 days, maybe 6 months. Whereas in the past, we had individuals on New York City Health and Hospitals was pretty much well known for having a very high retention rate. Our people would come and they would stay. And excuse me, there's a lot of opportunity for growth because we are so large. I began my career with New York City Health and Hospitals based at a hospital as a patient advocate. I've held many roles since. I've grown within the system. The system has afforded me with that opportunity. And so individuals are looking at that, but we have to hire with the idea of what can this person do for the role now in the foreseeable future, and not really get focused on we're going to have this individual for years to come. Because again, it's an employee market. They're going to go out there, the candidate is going to choose. And most often, the individuals that we have in our workforce today, even if they're not looking, they are being approached by different organizations. So we're constantly, even if we have somebody that's very engaged, if somebody comes over with a more aggressive opportunity, let's say, or development, they will reach out and they will say, and may come back, and there's a lot of counter negotiations going on. But there's a lot of opportunity for us to change the way we do work, to really look at the benefits package that we offer, to provide flexibility to the workforce. And we have to do so in a way that's really not going to affect negatively the patient care that we have. So the patient is at the front of it all. Anything that we do has to be guided by the patient experience, by the patient outcomes. So it's almost a balancing act. It's finding out who's the best candidate for the job, but who's the best candidate, where's the fit, and also organizational wise. Where are we as an organization? Is this truly the person that we need? And is the role being made in a way that will satisfy both the employee and the organization?
Thanks, Ivelesse. And Jenny, I'll turn it to you and I'll kind of repeat the question and add another portion just because I'm being mindful of time. I want to make sure that we get different kind of perspectives in here. So again, kind of how the pandemic has impacted your hiring and talent development approaches, but also if you can talk a bit about where you've seen increases in hiring demand in particular roles, and any kind of skills or credentials that are tied to that our service providers should be aware of.
Yeah, so I completely agree with everything that's been said so far. The pandemic has changed the way that we look at candidates for our organizations in a lot of different ways, right? So at the start of the pandemic, we had telehealth a little bit, but with the pandemic, that subsector of healthcare just kind of blew up. And the expectation was all of the existing workforce be able to like stand up and provide telehealth services while at the same time dealing with some very serious acute issues. In thinking about planning for like short, mid, and long-term staffing needs moving forward, it's about looking at resiliency, looking at technology, looking at skill sets that we didn't even really consider before, right? And because there has been a change in the way that the workforce or the public is looking at employment opportunities, the way that we look at how we're sourcing our candidates for our organizations has to change. So in the past, it was like, everyone wants to work in healthcare. Everyone wants the opportunity to get on career pathways in the healthcare system. And now they're like, okay, I'm going to tell you what I want, and you tell me if you can help me, meet that challenge. And so that has really changed the way that we are planning on staffing our organizations here in Brooklyn. It's really about figuring out what are the right screening tools so that's good for the individual who's interested in joining the healthcare workforce, but also looking at the organization and seeing what's possible and what are some hard non-negotiables, right? That we are healthcare providers, we have to see patients. If they have respiratory issues, I need to put a stethoscope on someone. I can't do that, through telehealth. And so there has to be some element of compromise. And I think that over the next couple of years, the way that we source our candidates will change significantly.
Thanks, Jenny. And I'll throw it over to Tanya. If you could talk a bit more about kind of skill sets that you're seeing on the rise, specific roles that you've been hiring for. And I know you particularly have an interesting perspective of both having a workforce program and being an employer. So I think that's a really good, you kind of straddle a very interesting middle ground there.
Sure. So I think that I agree with everything all my fellow panelists have stated. And coming from long-term care, it's unique. We were hit the hardest in a very different way when COVID began. So what I find, and maybe I'm sort of bragging, but at the new Jewish home, I really feel the employees' morale hasn't gone down, but employees are exhausted. Because we're a unionized environment, we actually have a pretty stable workforce, but where we have vacancies are on the clinical side. And, you know, I don't know if anybody watches TikToks, but there's all these TikToks about traveling nurses and international nurses, and it's so hard to get those contracts, and then they're not available. And you have to also be very careful about your staff that's there. You know, we have nurses that are dedicated and they're great. And, you know, you have to be careful that you're going to bring on a travel nurse and there's not going to be, well, why does that person get to float and I don't get to float? Or why does that person get to just come in when I've given you 25 years of my life? So it's an interesting perspective with recruitment, because it's not so much about retention, but assuring our staff that we're not forgetting you, we're trying to help you. So I think that's interesting. For the other positions, the New Jewish Home also has a workforce program, which we call GCD, the Geriatric Career Development Program, and it has two pathways. One is for high school students, and it starts in about 10th grade, and they apply. We have about approximately 3 to 4 cohorts per year, and what they do is they stay with us, they do their homework with us, and they learn how to be an employee. They do their clinical rotation to become a CNA at the New Jewish Home. And for the most part, we hire almost everybody unless there's really a reason why we can't, or they go to college. So that's the high school program. And what's fascinating about this program is that many of the kids, sometimes they're just joining to do something, and they will tell us that they really had no aspirations. You know, they were just trying to get into a union, or they didn't want, you know, one young lady told us that she wanted to work in a factory, and I guess I was shocked. I didn't realize there were still factories in New York City, and there's nothing wrong with that, but our workforce program has exposed them to a different way of life. And it's wonderful. Right now we're dealing with Harlem, both East, West, and the Bronx, but we are expanding to other boroughs and nationwide. We have a young adult program, which is very similar, and again with the CNA programs. And I just want to touch upon something. They are graduating as a CNA. They are offered a position, and in our organization, we are very fortunate to have 1199. And 1199 is, at least in New York, 1199 SEIU is just, what else can you say? It's just 1199. And the great thing about 1199 is once you're in there, we're training these young adults and children, young adults and younger adults, that they can go further. They can become a medical assistant. They can go work at Sinai or Monty. We don't want them to leave. Or you can become an LPN or an RN, and all that education is paid for through the union. And so for us, it's really working very closely with our union reps and ensuring that we are really promoting the benefits of working here. I do find that, you know, I guess you have to say the millennials, it's a different generation, and school is different. So I know for me, and I'm probably dating myself, but there were classes starting in junior high school that we took typing, or it wasn't computers, it was like a typewriter. And we learned, like, you're going to have to resume, you're going to have to learn how to interview. Whereas a lot of these kids are like, well, you know, if I don't have a job, I think there's like free benefits I get. And really sort of explaining to them that not only can you have a job, but it may pay your college. So you can get in now, and attracting them in a different way. So I think our program is great, and it has allowed us to have a pipeline of employees. And it's something that obviously we want to promote across the city and again nationwide. But it's wonderful because, you know, especially with the high school program, you've got them learning and they're with us for 3 years. And the difference between a hospital for long-term care is this is really our home. So I'm just going back to the stability piece. With COVID, we've not experienced the turnover, you know, I want to knock on wood while I'm saying this, that others have had. We have had a major problem filling the open positions. You know, for us, I think that when you're working in long-term care, you're forming relationships with people who are living there. We're in their home. Our job is in their home. So it's a different type of loyalty. And really expressing that, they get to see that and they feel safe. So it's a wonderful program. I think for my recruiters, I heard Gail say that, and I would agree, we are constantly touching our postings. You know, it's not unusual to find a posting that just no one has applied for 3 months, and I can call another nursing home and they'll say, us too. You know, do you have a nurse educator? By the way, if there are any out there, I need them. But the same thing with the CNAs. If they're not coming from this program, I am competing now. You know, before I competed with Mount Sinai and Monty, now I'm competing with McDonald's. I'm competing with Starbucks, which, by the way, pays IVF in their benefits. I mean, that's my mind blown. It's hard to compete with that. So how do I tell them, you know, come here, and it's going to be harder physical labor, but it's truly rewarding if you give it a chance. And I think that that's our struggle, but it really is just about constantly reaching out to the high schools, reaching out to the colleges, you know, reaching out to Hunter and saying, you know, we know you have your nursing school, and we know that you're probably going to NYU or to Mount Sinai, but this is what we can offer you if you have them train at the nursing home. And maybe if we get one, that's one vacancy that one vacancy less that I have to worry about.
Thanks, Tanya. And Dan, from a kind of community health perspective, would you be able to talk to us about kind of how you've been approaching hiring specific roles that you're looking for and that have been growing over the last 2 years?
Sure.
Yeah, that'd be great.
Yeah, no, I mean, I think that we had a perspective. There's always been a shortage in community health centers pre-COVID. We were always looking for helping, and COVID has just exacerbated it. You know, and then as James had pointed out, the number of individuals with Medicaid has grown by almost 1 million or 750,000. So demand is higher, staffing is less. That puts a lot more stress on the individuals that we do have that are delivering the care in our centers. So the people that you have working, you know, they're under a lot more pressure. So that's really difficult. I think is that you know, we used to have this sort of a vision, and many of the colleagues on the panel said is like, we're community health centers, we're doing good. We don't pay the best. Do you want to work for us and serve the mission and serve the community? You know, like people have changed, and that's not quite exactly people entering the workforce are like, well, I'm going to do this and give back to my community. 100%. Like, what am I going to get out of this, or what am I going to get out of this for my family, especially during these times? So we've had to shift from do you fit with us to how can we fit together? Because that's really critical. Because if you just say, this is who we are, do you like us? It's not working anymore for us, at least. I would also say, in a very process-oriented way, is our onboarding process used to take for various roles a very long time. And now it's like, by the time, you know, we had to accelerate it very fast because people going through the process were getting cherry picked by other people who would say, oh, we'll give you 2,000, 3,000 or this more. And so we were losing lots of people along the way. So so that was a process that we had to change in terms of our practices. In terms of roles, I wish I was just at Universal with my son last week when he was off. I wish I had one of Harry Potter's wands that could make 50,000 more nurses or LPNs or RNs for the state of New York. So nursing shortages for ambulatory care centers are in tremendous shortage. And I can't speak more highly about, the pandemic, in my personal belief, has created mass trauma for children, adults, everybody. No one has lived like this, as one of the panelists has said. So there's a huge behavioral health need, whether it's mental health or substance abuse services. So some of those are licensed positions, which we need help with in filling in our centers. But there are also a lot of outreach or community health workers who can go out, identify people, create those relationships in the neighborhoods, in the communities, outside of the bricks and mortar of the community health center, to bring people into care. And I think a lot of the workforce community can help us with those.
Thanks, Dan. Now I'm just gonna, go ahead, Tanya.
One thing I think none of us touched upon, and I think just again, because we're all so exhausted from COVID, is that we were also all, no matter where we're coming from, severely impacted by the COVID mandate, the vaccine mandate, and now the booster mandate. And not only have we been affected, and I'm very thankful to Hochul for extending the booster mandate for 3 months, but the feedback from the CDC and from our governments are just so back and forth that you have employees who don't want to do this, and they feel like they're being, held hostage to do so. And then the rules change so fluidly that they don't trust. And I don't think we're touching upon that. They don't trust the COVID vaccine or the booster. And then when the government or the CDC says, oh, you know what, you don't need it, or you know what, you do need it, or you know what, we can delay it, it gives a message to them that they're right. And it has affected our staffing, and it has made everybody mentally exhausted. And I don't think that's just line staff. I think that goes all the way up to the senior level. And I think we were caught off guard, and I see everybody nodding. I think we were very caught off guard thinking it would just be the caregivers, but you actually had members of senior management and management saying, I'm not taking it. And you're saying, oh, wow, this is not just patient care now. It's payroll, it's finance, it's ay. So I just wanted to put that out there because it did affect all of us.
I would just agree with you on that. We had a number of people. The number was a little frightening at first in terms of people who said that they were not going to take it. But I am happy to say that when all was said and done in the end, we really did not lose too many people after that. However, then it became the second vaccine, and then it was the booster. And I was like, oh my goodness. So I agree with you. I was happy that they pushed it out, a bit, because some people, they really did not want to take it, but they also needed their jobs.
I also wanted to add, just in terms of opportunities. So there are challenges, but we have specific roles that we're looking at. And so, for example, behavioral health. Behavioral health is huge. We have behavioral health, data analytics, IT roles, our CNAs, which is our PCAs. And so we're in a unique situation at New York City Health and Hospitals because one of the things we're doing is we're pipelining not only those high school students that may potentially go into those areas, but we're also looking at our individual workforce and establishing internal career ladder programs to equip people to move from one location to the other. And then we're also developing programs that right now we're working on with the internal workforce, but we're looking to expand to the outside. So for example, we developed a behavioral health associate academy, internal, shows de-escalation. It addresses everything that the individual needs to know. We started off by training individuals that are within our existing workforce that would like to move over into another area. We are now looking to pilot that and extend that to individuals that are interested in coming in as behavioral health associates. We'll provide the training and then have you accept one of our roles. Another thing that we did is we partnered up with CUNY. We developed the Data Analytics Academy. And so this is for all these roles that are hard to recruit. You may have talent out there that has the baseline. And so these individuals went through the program, and when they came out on the other side, they had the skills that we needed. Tableau, BI, all of these things that are important. We regularly are now going out into the community, partnering up with community-based organizations, CUNY, private schools, high schools, and really putting out there everything that we have available. Not only that, we're also asking the workforce and we're asking other individuals, what else would you need? So when it comes to that PCA roles, that's the easiest that for a staff. That's an entry-level role. You get your certificates and you can come in. But then there's also another area, and it's a potential area of opportunity that's, I believe it's unique to New York City Health and Hospitals in terms of the panel, which is out of the civil service pool. So for our entry-level roles in clerical associates, so you have clerical associates, different levels, 1, 2, and 3, we go through New York City Jobs. And so New York City Jobs enables an individual to take an exam, become part of a talent pool, which we then draw upon in terms of who we're going to interview to draw those individuals in. So one of the things that we want individuals to know is be aware that a direct line of employment is not always through the employer itself. So we go through many different avenues. And so that may be something that that the audience is not familiar with, that they may want to take advantage of. And I can absolutely put all the links up on the chat.
Thanks, Ivelesse. And that's a good kind of segue into the next part of the conversation that we wanted to have, that some of you have touched upon, which is really how can workforce organizations better partner with your organizations to either build out training programs or to support recruitment that you've talked about that are so challenging. Are there any kind of examples beyond the ones that you've talked about that should be scaled up or that other organizations should model? Or are there any gaps in the workforce development system that should be filled from, and kind of if you have any ideas there? So I'll open up the floor to whoever wants to speak.
I can start that off since I kind of finished it off with that segue. So we're always looking to partner up with individual institutions, with individual community-based organizations, with individual schools. One of the things that we are most interested in is looking at individuals that provide certifications. So for example, organizations that provide certifications in de-escalation. De-escalation is very important, especially in the behavioral health world. We have routinely partnered up with CUNY in terms of developing different programs. And as the Chief Learning Officer, I deal one-on-one with different organizations just in terms of if there is a need that we have, I have a roster. We also partner up very well with 1199. And again, they support our staff, and we are highly unionized. And I can't tell you, we have 1199, we have DC 37, we have numerous labor partners. And so one of the things that we look to do is we have an internal learning academy, and that offers non-credit bearing courses. It's generally soft skills. It's also the academies that you heard. But whenever there is a gap in what we cannot provide, that's when we're going outside and we're looking at individual organizations that can provide that. Those come possibly on a one-on-one, they flow in based on need. So one of the things that I would love to do is connect with the organizations that are here, exchange information, provide my information so that we are aware of who you are. And when we have a particular need, we can say, okay, you know what, if this is your niche area, this is what we have. How can we partner up? We are very happy and very open to partnering up with everyone there. And so it's just a matter of matching what the organization can provide to the skills gaps that we may have. And that varies on a day-to-day, but the big ones, absolutely. Data analytics without fail, behavioral health, hospital police, we have an academy for that as well. And then also your PCAs. So within New York City Health and Hospitals, we differentiate between a PCT and a PCA. A PCT is more entry level. A PCA is more equivalent to the CNA, which has the EKGs and so on and so forth. And so earlier on in the presentation, I did react to the pay that was quoted for the CNAs. It's higher. It's much higher than what was quoted. So that may make it a little bit more attractive to individuals interested in that entry-level role.
I mean, I would like to, oh, sorry.
No, please go ahead, Dan.
I would just like to add is that it really can be bi-directional, and we can work together as partners. Is that you know, our patients as community health centers are living in poverty, like 100 to 200% below the poverty level. So it's not just that we're looking for, I mean, it'd be great to get people to come work in our centers and staff them, but our patients are individuals who would benefit tremendously from participating in your workforce development programs. And they know our communities already. They live in the communities. Most of them come from communities of color, so they can help deal with the health equity issues that we're facing and racial equity issues that we're facing. So there really is benefits from both sides. So whether you're recruiting from in community health centers or we're recruiting from you to staff them, that is something that I would really like to see grow stronger. And I think Jenny's kind of doing that in Brooklyn and Bronx already. And I'm a little envious that I don't know about it in Manhattan. Maybe it exists. And if it does exist in Manhattan, please put it in the chat, because I will definitely reach out to you. But it works both ways.
I was just going to say that what you're doing, Ivelesse, sounds wonderful, because the challenge for us is that we don't have the opportunity to develop the pipeline. We're constantly chasing, and reacting. And we have tried so often to connect with the schools and organizations and the students that are graduating. But for instance, even with medical office assistants, a lot of the schools have closed. And the ideal situation would be for us to sort of home grow our own, medical office assistants or patient service representatives. But it's a little different when you're in a FQHC, for sure. But we're also with 1199. And one of the things that's wonderful about them for us is that they are offering some of their services to even include some of our non-union people in some education and further learning development. And that's always a beautiful thing. But would love to connect with everyone here, anyone that's out there that has, as I said, best practices or a pipeline of people that would be interested in talking to us and seeing what we're doing. I mean, one of the things that I would love to increase also is the marketing of what we do. A lot of people don't know what FQHCs are and what we do. And so getting the word out there and communicating would be wonderful.
Gail, can you talk a little bit more about efforts that you have tried to create a pipeline with CBOs that haven't worked out? What didn't work there?
Well, it's not so much that it didn't work, it's more so that it's slow. In terms of, you don't get a large number of people to, there's not enough talent to meet the need. That's really what it boils down to. So we are engaging with as many people as we possibly can. We're doing our own career fairs. We are engaging with anything that we have out there that might introduce them to what we're doing. But you still have to look for all different kinds of ways. I mean, one of the other things is that we haven't talked too much about it here, but the big thing now is DEI. And we're saying DEI-B, which is the belonging part of it. So people are very much into, what does your landscape look like? What is your culture like? How are people being treated? How are they, what's the growth development? There's a lot of components that's involved in it, but we are constantly reaching out there for any ideas that will help us to engage and introduce ourselves to anyone who's willing to work out there.
Great. Well, again, as I can see, there's a lot of interest in connecting in the chat, so we'll make sure to make those connections after the fact. Anybody else on better ways on connecting on workforce, creating tight pipelines? Jenny, I see yourself.
Yeah, I just want to add that, and I completely agree with Gail. Like, I don't think there are enough people out there to fill all the jobs that are currently available in healthcare, from like doctors to dietary to facilities. I mean, we just need it all, right? And I think that what has helped, and Ivelisse has such a great model, it is really going into the community and working with CBOs, because there are big segments of our communities that don't go to CUNY, don't go to SUNY, don't go to the healthcare organizations themselves to look for opportunities, but they do go there to their CBOs for other services. And it's really there where we can figure out like where the right matches. And I think what has changed because of COVID is, this the change in what the public is looking for in terms of a career in healthcare versus what we traditionally look at as careers in healthcare. All of that is, we're reacting to that now. And I think that while we're reacting to that, we also need to start planning for how to make that part of our day-to-day.
Great, thanks all. And, oh, did you have something else to say, Gil?
No.
Oh, okay. So the kind of last segment of the question is, the questions that we have is around public policy. So we've touched a little bit upon this. James touched upon some of the state pieces that need to change, but more from a kind of local, again, because we're a local policy organization, how can local government support you and your talent development and hiring needs through public policies? Are there any kind of, where should resources be most targeted, especially in ensuring that non-traditional talent and marginalized New Yorkers can access all the economic opportunities that you've been talking about so far?
So maybe I'll start. The American Hospital Association this week, I think 2 days ago, they submitted a letter to a Senate Oversight Committee asking them to look at different ways, waivers, other opportunities to change the way in which we reimburse people to study careers in healthcare, right? It's very expensive to become a nurse. It's very expensive to become a doctor. It's very expensive to become a surgical technician. Are there loan repayment programs that we can put in place? For healthcare professionals who are trained overseas, are there ways to facilitate that transition of overseas credentials to credentials here in the United States? During the pandemic, we saw like lots of different states look at really different ways to implement waivers to allow cardiologists who, you know, in their home country and who have immigrated to the United States to be able to use their skill sets as we struggled with the pandemic early on. You know, so and moving forward, we should really try to figure out, there are lots of people in this country who have valuable skills and that we're not leveraging because there are barriers in place. And we should figure out how to like get through those and connect people who are skilled with open jobs that are available today and 5 years from now.
And I couldn't agree more with what you just stated. I think that in terms of expanding loan forgiveness, tuition reimbursement, tuition assistance, even if you start doing this and you have commitments, for example, we had the Doctors for NYC program several years back, where we sponsored individuals to take the New York City to become physicians and then come work for New York City Health and Hospitals, different hospitals. And then by doing so for a certain number of years, they were literally getting their education funded. So there's so many different areas. And so not everyone is looking for a degree. Some people are looking for career paths. So don't limit the assistance that's being provided to just degree-bearing programs. Look at those largely solicited roles. Look at the gaps that we all have in common. I'm sure if I say clinical lab technologies, it's technologists, it's everyone's pain point. So fund programs for those individuals. And then in terms of getting them out into the community, again, fund the individuals that are going to go to the community and make commitments to work at the jobs that they need to do to fund the communities that we serve. I think that that's one thing that the local governments, the state government, the federal government, it's all about. I have so many individuals that reach out to me, not only those incoming from external sources, but also our own employees that are so adamant. They want to go back to school. They want to do this. They want to change careers. But the barrier there is the fact that they don't have the funds to cover their education. So Jenny, 100% in agreement with you.
And I piggyback so much of Ivelesse, and our backgrounds are so similar with what we're doing. I piggyback on that, and I see in the chat that people are, you know, asking about what entry-level jobs there are. I think it's so important in this day and age. The generations are different. They have different viewpoints. It's not really all about money for them. Sometimes it's just about a passion, or sometimes it's about a whim. And there are people who are delaying college for very different reasons. And you don't have to have a degree. We have food services, we have housekeeping, and people forget that there are managers and directors of those areas. Those are not areas to be looked down upon. Those are areas that we had a couple of months ago, and I was shocked again. We had 14 vacancies in food services. And, people were like, oh, it's food services. Yeah, I'm competing with Nordstrom Rack over there on 57th Street. So it's not just food services. And, for me, I really wish that the government, and I'm sure they do, but make money more available for training programs like this, and work more closely with the unions. And, it really sounds like I'm touting $11.99, but nice, no, UFT, DC 37, and really just give more money and form more partnerships where we can reach out to not just the pointed areas that we clearly need in terms of clinical IT, but the areas that are just as important, even if they don't have the education, and provide growth and stability. Because at some point, if we're talking about a younger generation, they are going to realize they'll start a family or their mind frame will change. But something will change. It did for all of us. Facebook won't be important. It will be checking my email. And I think that we have to keep that in mind. So I would love it if that could happen. We work with long-term care. We work very closely with AdGIS. We're a nonprofit, and we work very closely with Greater New York. And they are constantly pursuing these, because the reality is, yes, COVID hurt us greatly, and we continue to suffer. But nursing shortages, I mean, I left healthcare for 8 years, and when I left, there was a nursing shortage. And now I came back 8 years later, and there's a nursing shortage. So it's very cyclical, and we need help. We need help with, how you bring in people on visas. And I think that if that area were easier, we wouldn't only be looking at nurses. We would be looking at social workers or other, career pathways where we do need that help. I mean, if any of you have ever tried to get a licensed social worker, it's not easy. That test is hard. It's like becoming a lawyer. And, can we lighten that rule? Can we work with it? We were able to do it with COVID. We were able to work with background checks or how we onboarded people. So there has to be a way. And I think if the government were to step in, and again, I think a lot of it has to do not only with laws, but funding. And funding is there for that. So hear us and give it to us.
I mean, just to echo what Tanya is saying is, I think that if the federal government created, not the federal, I'm sorry, because you're local. So if the city government came out and said, like through a demonstration project or through some other initiative, we want workforce development and community health centers to come together and create a pipeline to fund them, we would run after that. We're not like, as Gail pointed out, like as some of the larger hospital systems, we don't have a huge infrastructure to create a pipeline. But if you fund it, if the city funded it, and that would be a great policy issue, fund it, give us money, like Tanya said, and we'll make it work, because we tend to follow where the money is, because we don't have a lot of it in community health.
I was also just going to echo that the landscape has changed for us, because at one point it was very much about the degree. I think you had to have a certain degree, and now it's more about the experience. So that has offered up more talent from that perspective, and I think that's a good thing. And so what we're all talking about, if the government came in and promoted programs to further train these individuals who want an education or who want to go a particular career path, it would be great, because we don't have the funds to do that.
Yeah, I mean, I'll say in the private sector, like in certain areas, when a company hires somebody, they get money from the government for everybody that they hire. I mean, we're all in the nonprofit sector. The government is not giving us any money when we hire somebody, and that money can be reinvested in creating a pipeline. But so it's that divide between the haves and the have-nots, really, I think, in some ways.
That's a good, it is advocacy season. We do have a new mayor who's very interested in supporting workforce development and really making sure that the recovery is equitable. So this is part of why we're doing these events and really kind of looking to our community to join us in our advocacy efforts in the next few months as we work with administration to make sure that this kind of work is moved forward, that the need for recruitment and talent is met with more investment. So we're certainly glad to hear that, you agree on your end that that's a need that is shared across the board. And we'll definitely be looking to you all for some advocacy support in getting that across the finish line over the next few months, as well as, all of our members in the chat. So, and again, it's very exciting to see kind of all the interest that everyone has. Like we said, healthcare is the more established sector training programs that we have amongst our membership. So I think that's why there's so much involvement you're seeing in the chat of people that want to connect with you to help you with recruitment and think through some of the particular, I think there's probably some potential here for figuring out if there's any particular roles that you're having a hard time hiring for, and building out kind of training programs or specific targeted outreach programs for those. So we'll work on the back end to make those connections and hopefully see some success between service providers and your organizations. So before we drop off, we have another 5 minutes. If each of you has any kind of final remarks or anything that you wanted to talk about that didn't get mentioned over the last hour, would love to hear from you.
At my work, I've been trying to convince everyone to connect with each other and build profiles on LinkedIn. And there's a resistance to social media, it's this and that. But I think what we're hearing here is that all of us have great connections or great partnerships with places. And if we're connecting and we all see and follow the same things, there's power in numbers. And we can connect with each other. Gail may have people applying that she can't use, and then say, Tanya, it's a networking platform, and it's a way to promote what we're doing. And more, the colleges are asking their students. I belong to a sorority where we ask the undergrad students to have LinkedIn profiles. And these are, again, young adults that you wouldn't normally capture, who might not even be interested in college or get a degree. Their parents are paying their loans, like mine, but anything like that. But really, it's a professional networking platform where we can find out about maybe obscure grants or a partnership with a company that we just didn't know. I agree with Dan. I think what, Jenny, you're doing at Maimonides, I already have down to email you to see if maybe I can connect that with my workforce development program. And I would have never known about that. And we prepped and I knew what your background was. And so I think I push for that because we all seem to, I'm seeing in the chat, we all are really passionate about either filling our roles or helping these young adults who, a great majority of them just have a need. They have a need, and I think that James's presentation said as much, and people of color remain at a deficit. And what I'm hearing is that there's no reason for that to continue. So that is my pull for LinkedIn. They should probably hire me. But I think that if we're all connecting, we can make an impact. Even if it's not at my organization, if I know that I can get these people who are unemployed, maybe you have a criminal background, maybe you can't be a nurse, but you can be other things and you can have a career, and life is not over. And it upsets me when I hear these numbers. So again, LinkedIn, partner with each other.
Couldn't agree with you more. I mean, it's really about networking, communicating, and not just saying it. Sometimes you serve on these panels, you talk, and then you never see the people again, you never talk to them again. It's really about really following through, which I plan on doing, which I think everybody here probably will too, because it's been very encouraging to know that it's always nice to know that you're not the only one, again, in terms of having the challenges and the struggles that you're going through with. And even though we are smaller than a hospital, I mean, we are from prenatal to geriatrics and everything in between. So we have family medicine, dental, behavioral health. I mean, it's a huge operation from that perspective that it's almost like one-stop shopping. So I look forward to connecting with all of you after this.
I echo those sentiments. I think it's connections, but it's developing meaningful connections. Let this be the beginning of the conversation and let it not end here. Make sure as we exchange information, make sure that we continue to connect with each other and really drive each other forward, because we are healthcare for New York. Regardless of where you're at, we're all here for one thing. It's the patient. And if we are the largest, and we are the largest employee hiring sector, let's make a difference and work together.
Yeah, and what I would add to everyone's comments is I think before COVID, during COVID, post-COVID, I think it's really important for training partners to really understand what employers need in delivering healthcare to New Yorkers. I think COVID brought to light some of the challenges of working in healthcare, and we saw lots of people leave healthcare as a result. And I think there are many people in the communities who see an idealized vision of healthcare and think it's one thing, when in fact the reality is very stark, and we saw that during COVID. So I think this is a great start to conversations with one another, and we'll be able to provide insight, hopefully, and get some great candidates from the community and be able to serve all the patients that we all see.
Dan, do you want to have a mic drop moment?
Yeah, I just want to say is we should all advocate with our city council members and the mayor's office for funding, because it's great to have connectivity, but it takes money to fund that. So we should all work with all of our organizations, whether you're on the workforce side or the healthcare side, and say fund some of these programs so we can get people in the jobs to take care of New Yorkers as they need to be taken care of.
Couldn't have said it better myself, Dan. Thank you for that final pitch. Super appreciate all of your expertise and your thoughts and ideas. I particularly appreciate all the connections that are going to happen after this moment. And, you know, really looking forward to seeing how that flourishes, and hopefully, you know, the best outcome is that people from our communities and our organizations are hired by some of your organizations. And again, also just really appreciate your openness and receptivity to both participating and offering your time to this conversation and working on building out those relationships. So with that, thank you so much, Tanya, Ivelesse, Gail, Dan, and Jenny. We'll follow up with you and share your contact info with everybody else. So that concludes the third installment in our Industry Needs by Sector series. Thank you again for joining us this afternoon. And of course, thank you once again to our panelists. Enjoy the rest of your day, and we'll be following up with some more information. Thank you.
Thank you.
Thank
Thanks,
you.
everyone.